So, thank you for coming to our palliative care nursing education forum today. As you know, this is a collaboration between Oxford, Elgin counties, and Huron and Perth. And as usual, my name is Sarah, and I am the consultant for the Huron and Perth area. And what I will do is Kate will introduce herself a little bit later as she moves through and takes over the second part of our presentation. So I just want to start by telling you, what are we really going to talk about? Well, we've introduced ourselves. We're going to look at the article that we're going to speak about today, and we're going to explain a little bit about why did we choose this article. And the article that we are looking at is Correlates and Predictors of Conflict at the End of Life Among Families Enrolled in Hospice. And then we're going to have a bit of a discussion. You'll notice it doesn't say we're going to have a case study at this point because we are maybe not going to do it that way. We're going to do things a little bit different. And we will, as always, we're going to record the presentation part, and then we will pause for our discussion, do a summarization, and get that up on our YouTube channel as soon as we are able to. So why did we pick this paper? Well, conflict. I know all of you that have joined us live in absolutely perfect families and have never met a family in conflict, but I hear they're out there, right? So I know we've all come across this in our careers, and it's important to remember that family conflict can have a large impact on the quality of life of a patient. And I think that that's something that we want to dig into. And even when you say conflict, what does that mean? It can have so many different impacts. That conflict can have a lasting effect on families. The conflict, if it's happening as somebody passes away, that person dies, the conflict may still be there. So that impact may not go away. And then thinking about, do we or should we even do any kind of assessment to see if there's any kind of conflict? Should we be screening for this? We screen for everything else these days, but for family conflict, how people are coping, do we or should we? And we're going to take a look a little bit deeper into that. So the aim of the paper overall was to look at things and see where are the things that line up and where are the predictors of family conflict towards the end of life. I think that it's really important for us to remember. We want to think about what contributes to this family conflict. We know that it exists, and we want to know that it's there, and we want to really take a big dive into that. There, it's finally gone. So levels of evidence, we look at this every time and every month when we come together, and you can see that our article from last week was down here in the background, or last month was down in the background expert opinion area. This would fall a little bit part way up, and we hadn't looked at a study like this. So we're going to look at this a little bit. That kind of goes into this idea, it kind of fits into just into the cohort, possibly a little bit down lower, but in the lower end of our pyramid. And that is why we want to look at as we go forward. So the actual type of study that we are looking for is, this time, it is a cross-sectional study. So what actually is that? And what does that mean? So I did a bit of digging and I looked to see, well, what is a cross-sectional study? And this is the kind of study where you're really looking for observations. We're not testing, we don't have a control group, we're not looking at it that way. We're looking at it as more of an observation. So there's a few different types that you can have like this, but in case control studies, then we're looking to see if we expose people to certain things, what happens. That's not the case in this section. You have that cross-sectional studies. Basically, what we do is we say we have a set of criteria that would make you included in our study. We have a set of criteria that would exclude you in our study. And if you meet those criteria, you're welcome in. And I think that's why it's a great starting point. And we're going to talk about some of that. So first of all, what are the strengths? Why would you use this kind of a study? Well, and it's important to remember that this is a very usually can be done fast, and it doesn't cost a lot of money. And that's what makes it a very attractive option for when we're starting to look at a topic. It's often the starting point. So before you start to plan a further study, or if you need a baseline of where are things at, this is a great opportunity. It gives us information. It helps us decide if we need to do more research, where should we start? What should we do? Now, what about the limitations of it? Well, the limitations are because we are looking at people at a moment in time, it's often hard to really draw those lines to say cause and effect, or what is the relationship between these 2 points. These studies can also be prone to certain biases because of how we're looking at it. One of the examples that was in when I was looking at these kind of studies said you could do a cross-sectional study. We could say we've got 5 people here on the screen with us, and we're all work in healthcare. So we're going to ask them about their opinion about a certain topic. So for instance, I'll just pick something that has absolutely nothing to do with it. We've got 5 people. They're going to say, we're going to look at what the best type of ice cream is in the entire world. And so they survey the 5 of us, we all give our answers, and then they come out and say, we've done a study, and the effect was overwhelmingly that it's vanilla. And I say that because it's my favorite type of ice cream, which I know isn't that exciting, but it truly is my favorite type of ice cream. I'm just not going to lie. So you can see how doing something at a moment in time, possibly you're going to do a big sweep and you're going to say, I'm going to interview 500 people and see if they feel that our country is planned for a pandemic, if we're ready for a pandemic. Well, if you asked those 500 people in January or December of last year or August of last year, the answer would be very different. And also maybe your impact. So it doesn't always give you that. The limitations are that they can have a lot of biases that really do come through that. And I want to really take the key to remember that this is an opportunity to look forward. It's about thinking about that. So if any of you here had thought, I'd always like to know a little bit more about something within your organization, looking at a kind of cross-sectional study would be a great starting point where it doesn't cost a lot of money. The opportunity would be there for you to work through it and to be able to learn a little bit more about a certain topic, about a certain disease, a certain group of papers or of patients. It's a great starting point for where we want to. So that opportunity certainly does exist. So I did have, not sure where it went. It is gone. I'll keep going. So we'll just move on and we'll talk about, well, what did the paper say? Well, first of all, before we get into the results of what the actual papers say, they talk about conflict and they try to derive what it really means. They talk about some of the challenges that caregivers have. All of us have seen clients that have struggled and that there's family conflicts and all the different parts that go to that. So it made the studying a bit difficult. They talked about all those different things. They talked about the adverse effect that it can have both on caregiver stress and on other parts of it. It talked about the negative impact that family conflict can actually have on the team's ability to provide care. And I think, that rings true, certainly to me, and I'm sure to some of you, where we felt like we were struggling because of conflict, that we couldn't really provide exactly what we were hoping for. So there's a lot of things, but what they truly felt was that families that had prior conflict in them would be a predictor of having conflict towards end of life. And they worked through and they came up with 3 hypotheses and 3 things that they wanted to test, and they wanted to look at those results. There's a few interesting points to talk about how they actually put the study together. And when we talk about the fact that these can have some biases, I think we need to just have a look at those so that we're understanding the results that are coming forward and some of the biases that did come through and some of the struggles that they actually had in doing this study. And yes, I know we did not pick a perfect paper, and we did that on purpose because in this type of study, you have to be able to look through and decide based on the biases, based on the struggles, how do I feel about the information and the results that they came out with? So they were starting out and they had great plans, as everybody always does when we're going to do a great research study, that they were going to have this great study. It was going to be offered out during the hospice admission process to families and caregivers. The only exception was going to be if the social worker deemed that they felt that the patient was going to intimately or very soon pass away, then they were not going to be offered the information. But what happened, as you can guess, is that they went through for the first couple months and uptake was very low and they were not getting a lot of recruits. So they actually had to do a pause and take a step back and look at what their protocols were and what they were trying to, to obtain. And then they stopped and they looked at it again. So what they did was they decided we're going to expand our criteria a little bit. We're going to, instead of having the social workers go through this, we're going to have them mention it, then we'll have people follow up, and then we'll go through another process. So what it ended up being is that the required families to follow up with the researchers in order for this process to go forward. So one of the biases and one of the concerns I had when I read that, I will be honest, is if you have a family that has a lot of conflict and has a lot of things going on, and you have a loved one that may be in palliative care or approaching the end of their life, and now you've been given more paperwork or another task to do. So there could be a large group that did not submit to this study because they didn't have the time, energy, or ability to be able to go through with that. And I think it's important for us to remember that. Another thing when they looked through it and they realized when they got through all of it is that a lot of the patients, when they went back through, it was not a very wide racial um, display. 99% of the patients were Caucasian. They did have a good mix in gender, but they did not have a good mix. So they weren't even sure. They even looked to see about some of the questions that they asked. Could that have been a bit of a concern? Did we ask the right questions about uh, how much, what your income was? That question was a bit confusing. And also they looked and saw what were those things that we were thinking about that we really wanted to put forward. They really felt that they couldn't disentangle some of those variables that they wanted to look at. And also they said that they did admit within the paper, it's actually on right in the discussion part, that they could not generalize these findings based on the fact that they did not feel that they had a very diverse or representative sample. So they even go as far as to implement the fact that they don't think that they can say that that is. And I think that that improves the outcomes and some of the things that I felt when I read the paper, because they do acknowledge that. They do have some information that they want to go through and when they're looking for it, but they do acknowledge that there were some biases and issues within it. So the first hypothesis that they wanted to look at is that they felt very strongly that the context of the family would be associated with the amount of conflict that was in the family at the end of life. And when they went through, they looked through that and they did all their testing. They felt that caregivers that had a history of family conflict had more demands, children in the home, all of those things would be higher conflict at end of life. And when they actually went through and looked at it, they did come out and realize that there was a relationship between that conflict, but no relationship was found between the conflict and the education level, the income, the duration of the caregiving, the relationship to the patient, or the presence of advanced directives. So this is an American paper, so they do use the term advanced directives within it, but they felt that they could look at that. So based on that, it was only partially supported because there wasn't strong evidence to say that because a family had conflict, meaning that it would have it at end of life. The next one that they looked at was they went through and they decided they wanted to see whether certain conditions would be associated with contributing factors in family conflict. And this is the one where they really like to highlight the fact of the relative, and they like to call it, and their term in the paper is coming out of the woodwork. So where you have a relative that becomes unwell, and all of a sudden there's somebody from out west or somebody who was not involved in the care before, and they have landed in, and they are within the care team now. And so they really wanted to see whether that had an impact and those kind of factors. And they interestingly found out that they did see that people who were having difficulties with activities of daily living actually had less difficulty thinking about the fact that their loved one was going to die. So when people needed more help, they actually felt they had less, they call it integrating death awareness. So they had, being able to do that. But they did find that having a relative that came from far away, or a friend, or the coming out of the woodwork, as they like to use, did correlate with a greater difficulty in that end of life passing. And so because of that, they felt that this as well was partially supported. And then they moved on to their third hypothesis. And their third hypothesis was that if we controlled and we took into account that family context and all those conditions, and those contributing factors would significantly predict the amount of conflict that you would see within a family. And so they looked back and they looked at that history of conflict. How old was the caregiver? They looked at, were there children? Did families take the time to sit together and talk about end of life planning? Had they had the ability to sit down and to really move through that? And when they looked through and they looked at, was there a relationship between whether people had had those conversations and done all that hard work starting out? And they felt that this actually was supported. So in the end, there are three hypotheses that they put forward. They felt two of them were partially supported with the information that they came out of, and one was fully supported. So when you look at the conclusion and you look at the study, they come out with a few questions and a few issues that they felt that routine assessment of family relationships would allow those most at risk to be able to be identified, and then interventions could be offered to them. So they would advocate, based on their information, that we should screen families and then be able to identify those that have the most conflict and be able to offer them some help. That open communication and discussions about end of life could prevent conflict if they were had before the end of life. Now, I feel like I'm telling you people all something that you all agree with in that sense. How many of us, haven't seen that, where if you had more open communication about what was coming up, about moving towards end of life before the last moments of death, how much better that can actually do. And it does actually have that strong correlation between reducing conflict at end of life. And it absolutely does acknowledge that more research is needed. But they felt that there was information within this study, both what they found and what they learned by what they wish they would have done, would lead them to help guide them towards those next steps. So it was an interesting read for me. I felt that there was some places where you could tell that they were trying to put variables together that were hard to prove that relationship, which is a problem within these types of studies. But there was some interesting information. I really feel like there's a lot of struggle sometimes in doing research towards end of life, because I'm thinking about myself. If I had a loved one that was moving towards palliative care with all the paperwork and moving parts, being asked to be part of a study may not be on the first of my list. And how open and how honest are people about the conflict within their family? So there was a lot of that was there, but I do feel it was a good starting point, and it was a good information that came out of that. So what I would like to do at this point is I'm going to pause my recording, if I can get my screen to come back up. And I'm going to...
Thanks, Sarah. So Sarah alluded to this earlier, that we sat with developing a case study for a while because we've certainly generated enough examples in our careers, and I mean, I can't speak for Sarah, but I can say even in my own personal life, to write a compendium on family conflict at end of life. And I'm sure many of you watching have as well, because there's so much dysfunction and conflict in families. And, I would just argue that some of us hide it better than others, but end of life experiences, they really do seem to bring out either the best or the worst in families. Um, Sometimes they highlight tiny fractures and bigger things happen. And we, as healthcare providers, we get to bear witness to all of it. So eventually, after throwing a bunch of ideas around, we decided that for this particular topic, we wanted to take a bit of a different approach. So instead of, if you've been following along with us over the last 4 months, we usually do a journal review and then we'd go through a case study. We wanted to foster relationship building and collaboration between all of those who have been kind of our regular customers for our nursing education forum, because really working in conflict at end of life, you need to take a team approach. It is so important. Sharing strategies and tips, making sure your care team is all on the same page and communicating the same message to each member of the family who's in a conflict is really critical. And let's be real, most of us are not officially counselors, even if we do play one during our day jobs sometimes because maybe there isn't someone else to support. But it's important to recognize when you're butting up against your own scope of practice or your own abilities, or maybe you're bumping up against your own trauma triggers in your own family, and knowing when to bring in reinforcements and to really work as a team. We also thought that this is a really great time of year to talk about family conflict. We are recording this on December 15th, and we are bombarded with imagery of the perfect family who, even in their squabbles, still manages just to resolve everything in 120 minutes, even though everything was awful. The reality is, life is not usually a Hallmark movie, which is probably for the best. But, it can be really difficult to walk these journeys with families. And, Sarah and I had some time to talk before before we presented this topic, and we talked about how, we're in healthcare and we're used to being able to fix things. We try a new dressing on a difficult wound. We increase people's pain medication. We ask for help when we're not sure what to do. And in some cases, it is nice. We can get that Hallmark ending. We can work with families to guide them to a solution to the conflict. But we also thought it was really important to point out that we're not going to fix 20 years of broken family overnight. And that's actually not our role in most settings. Our role is to keep the care focused on the patient. Because while we do want to make sure that we engage in that true patient and family-centered care, sometimes the patient piece gets lost altogether in situations of conflict. And we really need to bring that person back into the focus and back into the center. So what we decided to do rather than a case study was to facilitate an interactive discussion with all of our wonderful attendees, because we felt that it was really important to draw on the wisdom of each person that's been coming to Journal Club in how do you navigate these conflicts? How can we do a little bit of troubleshooting and problem solving as a small team in maybe how would I have managed this differently in hindsight? So we asked people to reflect and to share maybe things that didn't go well, because we can always learn from our successes and our Hallmark moments, but sometimes we learn a lot more from, we tried this out, it didn't really work. What else could I have done in hindsight? That's often a really valuable learning tool. So, some of the examples that came out of our discussion were, what do you do with that family when the patient or the resident, they feel like they have to perform for the family when they come in? They have to still be trying to eat or trying to get up out of bed, or they have to try and engage and be, sometimes you see the person who feels like they still have to be the center of entertainment when they're at end of life and they're dying. And, how do we support the patient in that situation? And you can see, so on this slide that's up right now, you can see we had some different types of conflict that we often see in our nursing practice at end of life. And so what do you do when families maybe disagree with the patient choices? And one of the things that we touched on there were a couple things. One, in working with families, sometimes you just confront the problem right up front. And sometimes it goes well. Sometimes people are super reasonable and pragmatic. Other times that's not the best approach, but we we drew on the phrase of a very well-loved PPSMC, so someone who was in our roles before Sarah and I, and she says, plant seeds and make it rain. So you just put those little pieces out and hope that people eventually tie together, oh, are we getting mom out of bed because she wants to get out of bed or because we want her to get out of bed? Or is she really enjoying eating anymore as we come in every morning and harangue her about, what did you eat for breakfast? Have you eaten anything today? Are you hungry today? Do you want me to make you anything? How do we help plant those seeds? So families sometimes need to come to those conclusions on their own. Someone else shared a really great tactic of, or sorry, I shouldn't say tactic, it makes it sound so serious, but another strategy of saying to a family, how does this activity benefit the patient? Or maybe when we're talking about conserving energy, what are the most important things that you want to be able to do with your mom per se? So you've been really focused on getting her up out of bed, but at the end of the day, you just want to sit and talk to her. So how do we help them see, there's only so much energy to go around? How do we focus in on what's most important to you as a family? Another conflict that came up that was kind of a conflict with family and staff is, what do you do when a family's not understanding where someone's really at in their trajectory and that they are dying? And the article talked about, and Sarah pointed to, that death awareness piece. How do you help families to understand when they're not getting it, that this person is dying? And in the example shared, sometimes we're also dealing with, some kids understand what's going on, maybe some don't, maybe the spouse is in denial that their loved one is dying, or maybe the patient's in denial. How do you navigate those particular challenges? And so we talked about how do you, again, keep the patient the center? How do you maybe have a family meeting and bring it back in so that everybody is hearing the same information at the same time? And then at the end of that meeting, confirming what people heard. Because it can be really challenging when one person's perception is, I heard this, and another perception is that I heard this, or maybe we're not. And Sarah pointed out that, it's hard right now because you can't just bring everybody together in a room. And sometimes we are trying to do things virtually with everybody in different spots. But how do you make sure everybody's getting the same message at the same time? And then we need that confirming of understanding, which is so critical, that we're not just like, we ran a fantastic family meeting. Everybody totally understood what I said because I am the greatest at explaining things. You've been around with us long enough to know sometimes we stumble our own words, and we really want to make sure that people understand what we were hoping to get across. So those are all key parts. We also talked about families at end of life and how sometimes, they're already in conflict. They've been in conflict for 30 years. And sometimes our role, it's not to fix it, but it's to kind of keep things at bay and try to keep families from fracturing even more than maybe they already are. Or for a family who's maybe not as adept with dealing with conflict because they haven't encountered a lot of conflict in their family. And now, as we said, at end of life, that's a huge stressor, and it can bring out so much in families that maybe they didn't even realize or didn't want to acknowledge was there. Sometimes our role is to help keep that focus on the patient and that gentle reminder of, this is a really stressful and challenging time. You don't want to say anything that you can't take back because, they're going to need each other going forward. We also touched on how we have to be really cautious and careful when we're maybe looking at things like reconciliation, or we're trying to support families in conflict, because we have, people have coping skills and strategies that they've been using. We need to make sure that we're not just meddling in something essentially that we're not going to provide supports with and how to deal with going forward. So one that comes up a lot in end of life is reconciliation between estranged family members. And that can be really lovely and beautiful. And again, at the hallmark moment of, people do reconcile and there is a coming back together of family. But we also need to be very cautious and aware that where there has been estrangement, or there is estrangement, that's usually not done lightly in a family. And we know from research done on families living with estrangement that often the person who is estranged they go through losing that family member over and over. It usually takes a few times before there is long-term estrangement. And they identify that it's almost like the person, they lose that loved one over and over again. And now there is a final death. So we want to make sure that if we are going to participate in things like that and facilitate that, that we're really making sure that we're wrapping supports around the whole family, particularly anybody who's being brought kind of back into the fold or out of the woodwork, as the article identified. So we then moved into talking about the article. Should we screen every family for conflict in an end of life palliative approach to care? And to summarize our conversation, I would say we came up with, what would you do with that information if you had it? Because sometimes it's really beneficial and it's really great to know that a family is at risk for conflict, or maybe they already have some existing conflict. That can really help guide us in how do we approach the situation. And if we take that trauma-informed piece of, not asking what is wrong with this family, but what happened to this family? Why are we seeing them behave in this way at end of life, and really get curious? So by screening everybody in advance, we kind of have a little bit of a radar up for them. But it was also pointed out, we want to make sure, what am I going to do with that information? And I said it's similar to, I came from acute care before I went into full-time palliative care. And there's a bit of a learning curve when you go into full-time end of life palliative care. You're not taking everybody's vitals every morning and do all of these assessments, and you're not checking lab values all the time, because the the really important question is, what am I going to do with the data that I have? And I often put that back to people. What are you going to do with the data that you have if you collect it? So we didn't really come to a conclusion of whether you should screen every family or not. I think that it's something we could even consider doing our own research on, or maybe you want to think about that in your organization. What would it look like if we screened every family for conflict? How would we integrate that into our care and make sure that we're using that information for good, and not allowing it to, maybe it was brought up, if I hear the more reasonable sides, do I take a side? How does that impact the care that I provide as a nurse in supporting families? So if you have questions or comments or concerns, please absolutely connect with Sarah and I. Our next session is January 26th, 2021. We will be meeting from 7 to 9 on our usual link, and it will then be posted to our palliative care nursing education forum on YouTube, which is where you found this video. We are still very excitedly putting together some great topics for the spring, but we'd really like to hear from people as to, what do you really want to learn about? What would you like to explore in the literature and then do a case study or have a discussion on? So please don't hesitate to reach out to either of us at any time. And then here are the references from today, again, because we did more of a facilitated discussion rather than a case study. We looked at our article. Sarah, as you know, talked about cross-sectional studies, which I thought was really great in looking at, sometimes we get overwhelmed by, how would I even start research if I wanted to do it? And a cross-sectional study can be a great way to dip your toe in the field of research. And then, as always, I feel like we're like a sponsored program, the Palliative Pocket Guide, or Pocket Book, because it is a really great reference for us in practice. So thank you for hanging out with us for the last half an hour or so. We hope that you learned a few things, and would love to hear from you if you have any questions, and we will see you next month. Take care. Bye.